This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. So welcome everybody to our special Journal Club series episodes here at PHM from Pittsburgh. If you're listening, this is now our take 2. And for those of you who are new, welcome. And for those of you who are regular listeners, welcome back. As you know or are learning, we're started in October of 2016 here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We've been coming to you since then discussing different topics on the American Board of Pediatric Content Specifications for Pediatric Hospital Medicine, and some contemporary stuff that demanded our attention, like our favorite virus, COVID. And one of the areas we were trying to figure out is the research part of the content specifications. As you know, this is the area where we learn how to critically evaluate the literature. As you can imagine, it's difficult to consider discussing this in an audio-only format. So to pull this off, we've partnered with our colleagues at Dell Children's Medical Center. Specifically, we're going to thank Dr. Lynn Thoresen for that partnership, and Dr. Philana Ling Lin, one of our pediatric infectious disease specialists here at Children's Hospital Pittsburgh. And we've put together this Journal Club series, and it's an experiment. We are going to see if this is an effective way for us to cover this topic. Now, and you're going to meet people throughout these episodes, and right now that's one of those persons. Our topic today is specifically cost-benefit, cost-effectiveness, and outcomes. And to help us with this, we have a very special guest, first time on the show, Dr. Lynsey Vaughan. I'm going to introduce Dr. Vaughan. We're going to welcome her on. Now, Dr. Vaughan completed her medical school education at the University of Wisconsin School of Medicine and Public Health and ventured to North Carolina for residency, completing her pediatric residency at Wake Forest Baptist Medical Center. And she was very interested in QI and value in healthcare and did a PHM fellowship at Children's National in Washington, D.C., which I was just at for PAS, and currently is in Austin, Texas, working as faculty at Dell Children's Medical Center. Now, in her fellowship, she completed a master's in healthcare quality and co-developed the value in healthcare residency education curriculum in D.C., and is now working on the same at the Dell Children's Residency Program. She co-developed and co-directed an elective high-value care course for medical students during her fellowship after completing the Dell Medical School course, Discovering Value-Based Healthcare. Currently, she's the Value Innovation Teaching and Leadership. She's in the Value Innovation Teaching and Leadership Program Vital of fortifying her ability to lead value-based quality improvement initiatives. And she's currently the Evidence-Based Outcomes Medical Director at Dell, creating evidence-based institutional clinical algorithms and guidelines, focusing on high-value healthcare and improving clinical outcomes. So now you see why we invited Dr. Vaughan with us. So Dr. Vaughan, thank you very much for joining us.
Absolutely. Thank you guys for having me. I'm so excited to talk about value as I'm super passionate and always willing to spread the message.
Well, that's good because we are here for the message. Now, as you know, this is a continuing medical education podcast, so we have to do our disclosures. I will go first, Lynsey, and kick it out to you. I was on the Sanofi Corporation's advisory board for meningococcal vaccination in immunocompromised patients, which should have no bearing on what we're talking about here. But now, Dr. Vaughan.
I have no financial disclosure.
Wonderful. All right. So, Lynsey, here's the question we always start with. And I know you know it's coming, and it's the basic one because this is not an area of expertise of mine. Why do we need to care about cost benefit, cost effectiveness, and outcomes? Why are we taking our time doing this?
I think unless you live under a rock right now, everybody knows that value is one of the hot topics in our nation. And I like to think about it as our national perspective as well as our individual perspective as to why this is important. And so you've probably heard before that the United States likes to spend an incredibly large number of our gross domestic product on healthcare. And so recently as 2021, the United States spent about $4.3 trillion or $13,000 per person on healthcare. And you would think, wow, that's great. We spend money, but we probably do better, right? That's not true. Our outcomes in comparison to other countries in the world, similar to the United States, are actually much below. Our life expectancy is below the world average. Our infant and maternal death rate is high, and we actually have double the obesity from the world average. And so those are just a few of the obvious ones that we should be doing much better with all of this money expenditure. So as a physician, we've actually found that we contribute to the waste in one of the highest domains. And so therefore, our individual decisions as physicians play a huge role in kind of thinking about value and thinking about cost benefit analysis. And then individually, of course, we all want better for our patients. We all want to help our patients get the best quality care that they can receive at the lowest price. And so I think that's why it's our responsibility as physicians to understand what's going on in the nation and with our patients to be able to do the most effective care for that.
Well, I couldn't agree more with that. So the value equation then, should we talk about that and how the cost plays a role and how do we do a cost benefit analysis?
Yeah, I think the value equation is a way that I like to simplify cost benefit analysis, cost effectiveness. And those two terms are actually very similar in that you're looking at outcomes and quality per how much you're spending. It's just the difference of units. One being cost effectiveness being more relative in things like patient death or quality of life, and then cost benefit analysis being a very actual monetary value in comparison. And so I like to think about the value equation when thinking about these terms because it simplifies it in my mind. And being a very spatial person and visual person, this may help those that also think this way. So the value equation at its core is looking at quality being the numerator over cost, the denominator. And so quality itself is often broken down into outcomes and patient experience. Cost can be broken down into many different things, like direct costs and indirect costs. So things like we have the patient bill, but we also have indirect costs like missing work, right? And so this value equation can change if you look at the literature based on the perspective. So I just want to note that this is the most basic value equation, but remember that there's different perspectives in looking at value. And so if you go look at the literature, don't call me a liar. There's lots of different ways to put numerators and denominators in this. Because the perspectives include patients, physicians, hospitals, and the nation, right? Government. Okay. And so that value equation changes a little bit, but at its heart is quality over cost. And so what you're trying to do with this equation is think about how we can make measurable improvements in patients' meaningful health outcomes relative to the resources utilized or the cost in achieving those improvements. And so I like to put this value equation in my head on rounds and go, okay, great. I'm thinking about how this is going to affect my patient outcome, this test, or how much does it cost? And what is my patient experience going to be affected? And using this equation, I can also help learners to grasp and look at, oh, okay, so cost effectiveness is big term. Let's break it down into this value equation and make it a little bit more digestible.
Can I ask, how do you explain quality? If quality is outcomes and patient experience, it's subjective. There seems to be a lot of subjectivity to it. How do you explain that?
Yes. So I think that's why there's a lot of difference between like definitions of things like cost effectiveness being this kind of, okay, let's put a more indirect qualification on that, like quality of life years, right? We see that in literature. Mm-hmm. Or, you can do it a little bit more with patient death. Whereas the cost benefit analysis tries to come up with a specific number that can make that a little bit less subjective, right? And so I often tell my learners on rounds that, we always like to think about in value. Oh, if I get this test, will it change my management of this patient? And that's kind of the old school way of thinking about value is why order something if it's not going to actually influence any decisions I'm making?
Okay.
But the subjective part of this is that you can actually add value by doing the respiratory pathogen panel, right? The notorious $1,000 respiratory pathogen panel, right?
Yes.
It may be so valuable to give that patient that answer and actually will increase the value for that patient going forward because maybe it will help convince the parents that they have a specific virus and they'll stop that from coming back to the emergency department. And that cost and things could be saved, right? And so, yes, you're right. It is very hard to necessarily put like a specific quantity on it. But I like to think about it in fluid terms and then kind of overall understand the basics of what things cost.
I see what you're saying. So like for the RVP, respiratory virus panel, which I've heard, depending upon who you're talking to and where they live and where they practice, can be $1,000 to $10,000. I've heard every number in between. But you're right. For that family that keeps coming back because it's this specific year has been awful for viruses. Their kids gotten sick a bunch. They're, of course, worried. Do they have a periodic fever syndrome? Do they have immune deficiency, which I've had people ask me numerous times for their child, or God forbid, cancer? When you can give them, look, your child was positive for these 3 viruses, which they probably had back to back to back. You're saying that patient experience part of that quality numerator goes higher, which increases their value in their value equation.
Yes, exactly. And then by proxy, hopefully decreasing costs in the future that would have been expensive emergency department visits or readmissions, right? And so I'm not advocating for the use of the respiratory pathogen panel. Believe me, it's not my favorite test. But
we would get so many emails if we did. Oh, goodness.
I know, right?
We're just, as an example, we were using.
It's an example where sometimes I break down with my value self and say, even though this isn't going to change my management, it might actually be valuable to this family, to this patient in this very specific scenario. And so that's where I like to put in the outcome, the patient experience that I can't measure and put some value, quote unquote, on that specific subjective piece.
Okay. All right. I think I understand the value equation. Where do we go from here?
Yeah. So I think we can talk a little bit about what does that value equation mean in terms of, kind of the coin terms that we're using in today's society, right? And so when you think about research and think about the topic that we're trying to tackle here, we often hear terms like high value care and low value care. And I think it's important to talk a little bit about these. High value healthcare seems very obvious, right? We want to improve high value healthcare. And what are the best examples of high value healthcare? So things that avoid you do now that may have hopefully smaller costs that actually prevent significant costs later. So you're putting a little bit more money up front sometimes to get better quality. Great examples of that. So immunizations in children is one of the best examples, right?
Yeah.
If you don't treat and get that H flu vaccine, you never know what that's going to look like kind of going down the line, right? So, So that's one example. Another obviously is the cancer screening that's well researched, breast cancer screening, things like that, colonoscopies. And then a third example, which is coming way more prevalent in our PHM community, is complex care patient coordination, right?
Okay.
Spending time, spending resources up front to make transitions smoother, to get patients what they need. So hopefully you're preventing readmissions and worse illness down the line.
Okay.
So high value healthcare in that value equation, you are really trying to improve that quality numerator and then hopefully putting a little bit of extra cost in, but the long road is that you're decreasing costs. Low value healthcare is a little bit different. One of my favorite examples of this is actually choosing wisely. I love that campaign. It's great. It's gorgeous. It tells us all about the things that we do potentially for no reason or that actually may harm a patient and how we can go about decreasing our low value healthcare. And so those things are like unnecessary testing and imaging. So bronchiolitis is our favorite example. Mm-hmm. Chest x-rays, albuterol, those types of things, cause potentially harm, right? Radiation, but, aren't necessarily evidence-based to improve outcomes. So those types we like to think about low value healthcare in decreasing the unnecessary testing that we're doing. And a lot of the quality improvement, different types, the lean methodology actually focuses a lot on decreasing low value healthcare. Which is kind of a different way to think about that value equation.
So then high value healthcare is using things that are relatively cheap. There are some costs to them to decrease bigger costs down the line. Immunizations is a great example. Low value healthcare is doing expensive or even tests or treatments that really don't work or really don't do very much for you at all, decreasing those costs by not doing them. Is that right?
Yep, those are kind of the most basic way to think about it. I think we expand those definitions very liberally, right? And we use high value healthcare and, as anything we're doing to help improve the patient quality. But at the core, those kind of are the original definitions.
Okay. All right. Now, should we talk about, you brought up the lean methodology. Do you want to help us know what that is?
Yeah, so this is, kind of like, why would the ABP ask us to put this in our research?
That's one of my questions, right? Why is this in research? Thank you for answering that. Go ahead.
Because, of course, I look at the specs when you sent them to me. I'm like, that's a weird place to put that, but it actually makes sense. So anytime you're doing research, right, you are actually thinking about patient quality. You are actually thinking about cost effectiveness. You are trying to improve a treatment. You're trying to improve a system, a process that's actually going to hopefully make things better for your patient, for the hospital, for yourself as a physician, right? Any of these processes are doing that. And so the lean methodology is an example of a quality improvement methodology that focuses on trying to decrease low value care. But there are all different versions of quality improvement that focus on, again, trying to improve quality, decrease costs, decrease waste, and in just other different forms. And, like basic research, RCTs, things like that are inherently doing the same thing, right? They're trying to compare one treatment to another and finding which one is going to give the patient a better outcome and hopefully thinking a little bit about cost and affordability in that scenario and choosing the best one.
Okay. So now the next thing we wanted to cover here, unless there's more I'm missing, is understanding cost charges and reimbursements.
Yes. I think this is important to talk about just because you look at a value equation and you look at cost and go, what does that actually mean in today's society, right? So if a patient comes to me and goes, how much is this going to cost me, right? You're like, I don't know that I have the best answer for that, right? And the reason...
I'm more straightforward. I tell them I have no idea.
Exactly.
I have no idea.
Exactly. And that's why physicians have a ton of discomfort around talking to patients and families about costs. And so I want to throw out the most common definitions from a patient perspective of what costs, charge, and reimbursements are, so that maybe in the future you can actually give a little bit better answer than, I don't know.
Yeah.
So costs are, I like to think of it as what a BMP costs the hospital to do, right? So obtain the BMP with supplies, with nursing, it's sent to the lab, it's run, and then it's reported in EMR, you're paying a lab tech, nurses, blah, blah, blah. They come up with a cost that says, it actually costs me this much to do this test, right? And so let's say the BMP at an institution is $150, right? Which isn't out of the realm of what I've seen.
Right.
So then you go, okay, so the patient, it's going to cost the patient this much money, but it actually doesn't. And the reason is because the hospital is a business just like any other, and it wants to make a profit and or stay afloat. So what they do is they upcharge. So what a patient sees on a bill is that upcharge. And that might be $250 at an institution, right? So that increase in $100 is actually what the patient sees for the hospital to kind of make money or stay afloat, right?
Right.
To complicate that further, right? Most of us, hopefully, have insurance. And so the patient runs their insurance first through all of these costs and charges, right? And is going to get a bill at the end of the day. But what does that mean, right? So reimbursements are what the insurance companies negotiate with hospitals as to say, hey, for BMPs, I'm going to pay you exactly this much money every time.
Right.
And that's what is taken off that patient bill, and then the patient will see the rest of it, right? So the insurance will cover a portion of that, but the patient might still see some charges.
Yeah.
And so this whole complicated, convoluted thing, we go, okay, yeah, so you want to know how much a BMP is going to cost you. That's a great question, right? And I think that's why literature shows that physicians are very uncomfortable talking about this, right? And that's why our society does not make this question easy.
No, because then insurances will sometimes negotiate with hospitals and pay a set amount, which you have no idea as a physician what that is. And I wonder, in the value equation, cost is the denominator. When they say cost, do they mean which are the costs? Do they mean the hospital charges or actually what Medicare or Medicaid are paying hospitals for those charges?
That's a great question. And so that gets back to what I was talking about when that value equation changes, right? From the perspective you're looking at it. Okay. So in the sense of, it'll probably be a charge when you're talking about a patient perspective of quality. But when you're talking about the hospital perspective of quality, they're probably talking about their costs, right? And or incorporating reimbursements from insurance, right? And then if you're talking about the nation, right, or the government, they're probably talking about just overall costs for like health outcomes for the year in the nation, right? They're talking about even broader categories of cost. And so that's why that value equation can change a little bit based on the perspective of the person that's evaluating the scenario.
So the variable used in the denominator will be different based on who's asking and what they're asking about.
Yes, exactly.
Remarkable.
Yes, I've looked at some kind of recent studies that summarize this really well, that actually show and lay out, this is how we look at the perspectives. This is why it's so confusing. And it's really interesting to see somebody kind of go back and say, yeah, the value equation changes, these definitions change, all based on who's looking at it.
Well, that's very helpful for us.
Well, it is very helpful. But what I would like to say, though, even though it seems daunting,
yes,
we have a couple of tools and things that can help us talk about these things, right? So I personally like to, within my institution, get a better grasp of at least the cost and or the charge sheet the master charge list from my hospital, and kind of scan for the most common things that I order and parents and patients ask about, right? Okay. And so when they ask me that question, I can at least give them this actually, the charge for this is actually this much money. I don't necessarily know how much your insurance will reimburse you, but know that it's probably not going to be the whole thing, right? Depending on deductibles and things like that I won't get into, right? But I like to frame it in a sense of, okay, I understand from my institution or the healthcare blue book that's online what the cost can or charge can be, and then describe to them, well, your insurance might cover a piece of this, or it may not, or you may not have hit your deductible, or you may have, but this is how much this test costs. And you will find that patients and families are actually really receptive to that information, and it does drive some of their decisions. In the literature, it shows that overwhelmingly patients and families, even in pediatrics, do want to talk about cost in their decision making. It is well documented that they actually want to talk about this. And so You will get those rare scenarios, of course, where you might feel like, oh, I'm worried that this is going to affect our rapport.
Right.
But I think overwhelmingly most patients and families are very grateful to have this conversation because, like you and I, we're probably, embarrassed to talk about any time we have trouble with finances or may not be able to pay for something.
Sure.
And so sometimes I just open up the conversation by saying, are you at all worried about costs or charges? Can I help and get my financial representative involved in your care? And when they say yes, I'm often like, okay, this person definitely wants to know a little bit more about what's happening as far as monetary stuff and quality in their care.
I have never asked that to a patient. I think that sounds really great. And in your expertise and your experience, they've responded really positively, you're saying.
Yep.
Absolutely fascinating.
Yes. It is surprising how many patients want to talk about this, but we just don't because we don't know how. And there's a lot of different resources. Even there's a lot in the adult literature about how to talk about cost. And obviously I take bits and pieces and make it my own for pediatrics, but I feel general questions are a great opener. And if they say, no, we're good, I'm like, okay, great. Maybe they don't want to have these conversations and that's totally fine. And then we just talk about it on rounds with my learners and we make great decisions for what we think is, the best that we can come up with for our patients in quality and cost.
Well, that was a very nice little tidbit there. Thank you very much. Now, Lynsey, I always ask our guests as we're wrapping up closer to time, is there anything we didn't talk about that you felt we should have or needed to?
I mean, I could go on for days and days, so I will just say that I really do think that it is our responsibility to think about these things and to teach our learners. And our patients want to know, our learners want to know, and it's something that we should try to feel a little bit more comfortable with. And kind of getting somebody within your institution that can kind of help teach about this is always a great idea. Somebody like me who gets really excited and wants to kind of help out in this domain. But it's a really exciting topic and it's not going to go away. So,
well, if we have this topic pop up again on the podcast, which we will, we're going to reach out to you. You'll become a friend of the podcast.
That sounds lovely.
Thank you very much, Lynsey, for your time. We really appreciate it. This was a great discussion.
Awesome. Yeah, thank you so much for having me. And again, I look forward to hopefully doing this again soon.
Yeah.
Thank you for joining us for this Journal Club series at PHM from Pittsburgh. We want to especially thank our expert guests for their time.
Special thanks to the University of Pittsburgh for sponsoring the CME for this podcast, and UPMC Children's Hospital of Pittsburgh for supporting this podcast as well. We want to thank our friends at Dell Children's Medical Center and the University of Texas at Austin for their partnership on this endeavor.
Please email my dad at tony.tarchichi@chp.edu with any questions or comments. And as always, thank you for listening!